Hello and good evening, everyone. I am Dr. Ajinkya Nanavare from MQR Pharmaceuticals. I welcome everyone to the No Thrombosis workshop in acute ischemic stroke. In the previous workshops, we had in the previous workshops we had very unique and interesting case discussions, and we are looking forward to have a fruitful discussions today as well. The objective of this workshop is to showcase unique cases in the management of acute ischemic stroke and gain insights from the moderators and the wisdom shared by our course director. And it is my honor to introduce our faculty for today. Let me share my screen.
Will you speak a little louder, Ajinkya?
Sure, sir. Am I audible now, sir?
Yeah.
So, first, I welcome Dr. Ichapuria, sir, our course director. Sir is Director Neurology at Sahyadri Hospital, Pune. And Sir has the first Neuro ICU and Neuro Intensive Care Unit of Pune. He has been the pioneer in the thrombolysis treatment for stroke in India. Sir has more than 300 public lectures and workshops on stroke. Sir has member of Indian Stroke Association and the organizing president of StrokeCon 2012. He has been also organizing president of ISS Stroke School. Sir is founder of Pune Stroke Group, ex-president of Society of Neurosciences, Pune, Maharashtra Academy of Neurology. Sir has been principal investigator for many multinational trials like Perform trial in stroke and Rensgate trial in stroke, and he has been awarded as health icon by the Times of India Group. Dr. Ichapuria, sir, welcome to No Thrombosis workshop.
Thank you so much.
Then I welcome our first moderator for evening, Dr. Jindal, sir. Sir is director and HOD at Department of Neurology, Max Super Specialty Hospital, Shalimar Bagh, Delhi. Sir has been a member of Indian Academy of Neurology, member of Indian Epilepsy Association, member of Delhi Neurological Society, life member of Indian Stroke Association, and also a member of World Stroke Association. He has attended various national and international conferences. Sir has been principal investigator at Jindal Neurology Clinic for epidemiological profile in migraine patients. Sir has done multiple social awareness programs through national TVs, FM radio, and newspaper articles. He has special interest in thrombolysis in acute stroke, neurocritical care, neurorehabilitation, epilepsy, movement disorders, and headache. Then I welcome Dr. Anil Venkatachalam, sir. Sir is senior consultant in neurology at LTMNC Medical College, Mumbai. Sir has more than 20 publications in peer-reviewed, indexed, and international national journals. Sir has wrote three book chapters as well. The areas of specialization are movement disorders, Botox therapy, and deep brain stimulation surgery. Sir has done a talking poster presentation at AAN 2015 and also received UCB's Young Neurologist Scholarship in 2008. Dr. Anil sir, welcome to No Thrombosis workshop. Then I welcome our first speaker for evening, Dr. Bhadresh Mangukia, sir. Sir is consultant neurologist at Mangukia Clinic, Neuro Clinic, Surat. Sir has done observership in electrophysiology at Sri Chitra Tirunal Institute for Medical Sciences and Technology, and he has done more than 6 publications in various journals. Welcome, sir. Then I welcome our second speaker for evening, Dr. Chetan Chaudhary, sir. Sir is consultant neurologist at Chaudhary Neuro Hospital, Jalgaon. Sir is winner of Torrent Young Scholar National Award in Neurology in 2014. Sir has done more than 8 publications in various journals. He has memberships of Indian Academy of Neurology, associate membership of International Headache Society, and life membership of Maharashtra Association of Neurology. Welcome, Dr. Chaudhary, sir. And with this short introduction, I would like to hand over this session to our course director, Dr. Ichaporia, sir, for his opening comments and context setting. Dr. Ichaporia, sir, over to you.
Yes. Good evening. This has been a very interesting program for many of us, and we have discussed some fantastic cases over the last few months. I think this is the 8th or 9th program. I think many people have benefited from this, and many young neurologists have been introduced to stroke treatment, and they have presented some wonderful cases, and we are very thankful to them. I am very happy to welcome Dr. Jindal, who is a senior neurologist and stroke specialist from Delhi, and Dr. Anil Venkatachalam from Mumbai. Both of you are coming on this forum for the first time, but I'm sure that you will really enjoy this program and contribute handsomely to all the discussions which happen. And I'm sure the discussions will be very good. So we will start now with the first case. Dr. Jindal, would you like to say something, some few words? You're on mute.
Okay. Thank you, sir. Thanks for your kind words. And definitely, I'm going to enjoy with your company in this session. And stroke is my one of the very interesting area in neurology. And for last 6-7 years, I am doing a lot of thrombolysis. Earlier, I was attached with the Agarsen Hospital in Delhi. And in that hospital, in around 5-6 years, I have done more than 600 thrombolysis over a period of 6 years. And lately, for last 2 years, I have shifted to Max. In Max, in my unit, I think in my hospital, in the Max at present, the thrombolysis rate has gone down. We are not getting much patients, around 4 to 5 cases per month. And previously, I was doing around 15 cases in a month, thrombolysis. So I have experience of both Altiplase as well as Tenecteplase also. I have used many cases with Tenecteplase, and I found it to be useful in acute stroke.
Wonderful, wonderful experience, sir. I'm very happy that you have hit century after century. And
Yes,
you know,
sir.
we want everyone to hit century after century, not to do 5 cases and 10 cases and 15
Yes,
cases.
sir.
You have to hit centuries. And
You
unless
have
you
to
hit the centuries, you will not get the expertise, and you will not see the real benefit and the happiness that the
Yes, sir.
patients get with stroke thrombolysis. And even we get tremendous amount of happiness with
Yes, sir.
with doing this. And this is a field which is exploding by the month, by the minute. New
Yes.
things are coming, new concepts are coming. So we will be very delighted to hear your experience after we discuss the cases. Dr. Anil, would you like to comment, please, before we start
Yes,
off?
sir. Yes, sir. So it's been a pleasure actually to be here. I know a lot of people will ask, what is a movement disorder specialist doing? Actually, I thrombolyze a lot of cases in like private. I almost thrombolyze around like 8 to 10 cases a month in various hospitals. And that's one thing which I don't leave actually. Even if it's late at night, I do go and I ensure that the patient is thrombolyzed if the patient is in the window period. So it's something which I feel, we should all be aggressively pursuing. And I'm very passionate about that aspect because I think that's one of the treatable aspects. We can't just let a patient have weakness and just lie like that. That's something which we owe to our patients. And that's something which I think every neurologist should aggressively pursue, because as it is, we have like very few things in our hands that we can actually treat. And if we leave even those things, then we would not be really doing justice to our patients. So I would also like to learn from the cases, and it would be a pleasure to learn. And if I can give my inputs also, I would be glad to share that.
Yeah.
Yes, thank you.
Only one thing, Anil, you have to change your biodata a little bit, and you have to add all these thrombolysis cases in your biodata.
I will, sir.
Yeah,
I
so I
will.
think now it's time that you change it a little bit and add all these things.
I will, sir. Surely.
Okay. So
Thank you, sir.
on that happy note, now we can start. Who is taking the first case?
Dr. Bhadresh is going to
Dr. Bhadresh?
present. Hello, Dr. Bhadresh, sir. Hello.
Dr. Bhadresh, are you there?
Yes, he's there by my phone.
Okay, till he comes, why doesn't Chetan take up the case? Chetan Chaudhary, are you ready to take your case?
Yes, sir.
Yeah,
Yes,
I
sir,
think we'll start with you then.
Yes, sir.
Till Dr. Bhadresh joins.
Yes, sir.
You can share your screen and start off.
A very good evening. Very good evening. Am I audible, sir?
Yes, you're audible, visible, everything good, first class.
Thank you, sir. 20-year-old male came with, he has history of neck pain and left upper limb radiating pain since 3 to 4 days. He presented to orthopedician on 27th May 2022. At that time, orthopedician evaluated him. He has done his cervical spine MRI and whole spine screening. It showed mild disc protrusion at C5, C6 level. Rest is unremarkable. So this was the MRI which was done on 27th May. It shows mild disc protrusion here at C5, C6 level. Rest is unremarkable, and his spine screening was also done at that time. It was normal. On 29th May, that is after 2 days of his symptoms, he has sudden onset neck pain, headache, and mild back pain, and followed by weakness in both lower limbs. Also, he has noticed numbness in his lower limbs. And his cousin sister has similar paraparesis few years back. She was having residual paraplegia. I have seen her at that time in 2017. And she was diagnosed as having ischemic myelopathy at that time. And she is still having residual paraplegia. So with this background, family is well aware of the consequences of this paraplegia. So they know where to go. They were living at village place at around 50 kilometers from Jalgaon. But because they were aware of this paraplegia and spinal cord infarction and all these things, they reached hospital within 2.5 hours, that is at 11:30 p.m. Symptoms started at 9 p.m. and they reached hospital at 11:30 p.m. On examination, pulse was normal and all peripheral pulses were well felt. He doesn't have issue of abdominal pain. Blood pressure was normal. He was conscious oriented. Upper limb power was normal. Power in lower limb was 0. And he has sensory level at around D10, D9 level. His pain and temperature and crude touch was absent, but I have checked his vibration and joint position, they were preserved. So at this time, at around 11:30, 11:45 p.m., it was just 2.5 hours from onset. And he didn't notice urine retention at that time. The problem at 11:30 p.m. was MRI technicians were not available. I can do that MRI by calling the technician, but it would last around 1 to 1.5 hours calling the technician and getting MRI done. So luckily, I have the MRI which was done 2 days back. He have dissociative sensory loss. Typical symptoms are anterior spinal ischemia and no symptoms suggestive of aortic dissection or spinal hematoma. I have discussed the scenarios with relatives, explain them the worst consequences if may happen, and decided to thrombolize him because this is very typical of anterior spinal cord syndrome. And the MRI was done 2 days back. It does not show spinal AV malformations. And there is no symptoms which suggest spinal hematoma at that time. And to this surprise, in next few hours, his power has improved from 0 to 5. Still, some numbness persisted, and only partial numbness was present below D10 level on the next day, and he started walking on the next day. Next day, I have done his MRI, whole spine, brain, as well as brain angio. Spinal angio is not done here in Jalgaon. Brain is normal, spinal cord also is normal. Whole spine screening, whole spine MRI is also normal. A spinal diffusion I have tried, but it was not available here. So spinal cord diffusion I could not do at that time. His other investigations were normal: hemogram, sugar, lipid profile, echo, coagulation parameters were also normal. And after 5-6 days, I have discharged him on antiplatelets, and no residual weakness was present. Only some numbness were present in the legs below D11 level at the time of discharge. He is still better. He is on antiplatelets at present. Acute spinal myelopathy because of the ischemia is of rare occurrence, and very few thrombolysis is done in spinal cord ischemia, because sometimes means there is very less awareness amongst other specialties like physicians, orthopedicians, etc. And general public is not aware. This patient is unique in that because his cousin sister has similar spinal cord ischemia, and the family is well aware of the consequences. If they would not be aware of the spinal cord ischemia, they would have gone to the orthopedician first. But in this case, it was unique that his MRI was available. It was done 2 days back. Family is aware of the spinal ischemia. So they have presented to me in 2.5 hours. In this series of 4 patients, which was presented in International Journal of Stroke 2019, 4 patients of ischemic myelopathy were given IV thrombolysis, maximum within 245 minutes, that is around 4 hours. And favorable outcome was achieved in 2 patients rapidly, within few hours, and in the rest at 3 months follow-up. So the key message is anterior spinal artery syndrome can be diagnosed through thorough history taking and neurological examination. Thrombolysis may have the effect and should be tried during first 4.5 hours. This is the very important point, and we should make more awareness among other specialties as well as in general public about the spinal cord ischemia. Aortic dissection and spinal AV malformations must be ruled out before thrombolysis. So 2 tests we have to do, that is CT aortogram and spinal cord MRI. These 2 tests are must before thrombolizing the spinal cord ischemia. Thank you.
Very wonderful case, I must say. Dr. Jindal?
Yes, sir. Hello.
Dr. Jindal, would you comment, please?
Yes, sir. So it's very good case. Dr. Chaitanya has done very wonderful job. In fact, it's a very anterior spinal artery thrombosis itself is very rare entity, and most of the time it's misdiagnosed. It's not diagnosed, and the patient present very late with another ischemic myelopathy. In my clinical practice, rather I have a very interesting case. My old patient, twice he was earlier thrombolized for brain stroke, and third time again he presented to me with me with the acute posterior circulation stroke, left PCA infarct. That was a very small infarct, and patient don't have much deficit, and he was out of window period. So I just admitted the patient because earlier 2 times he had stroke. So I was just investigating further, and we done the routine investigation, echo and all that, and we did the Holter, and we were planning for cerebral DSA. I asked my colleague to do the cerebral DSA, and after performing DSA, patient developed quadriplegia. Patient was conscious oriented, and he became quadriplegic. Then immediately in my mind, I thought it has developed anterior spinal artery thrombosis. Clinically, there was this thing, sensory dissociation was there, and the patient was fully conscious. Immediately, we did MRI brain and MRI spine with diffusion sequence. So there was an infarct in the spinal cord. So all that happened in the ICU setting only. So immediately, I thrombolized the patient with altiplase, and he had made a very good recovery. So this was rather quite unusual that after DSA patient developed anterior spinal artery thrombosis.
Dr. Anil?
Yes, sir. Excellent case. So it's an excellent case. And also, I would appreciate the promptness with which Dr. Chetan has intervened in this case, because a lot of times we are a little bit hesitant when the MRI is normal, when other things are normal. He's actually backed his clinical judgment and he's gone ahead. As we know, anterior spinal artery thrombosis is a very rare event. And also thrombolysis per se is based on anecdotal evidence. So, I mean, I really need to hand it to you, for actually taking that call and that judgment, and also the risk. Because we know that once a patient is paralyzed, he'll be completely paralyzed and there's no chance of improvement or recovery in such cases. So, I mean, excellent. Especially the presence of mind and the judgment that you have taken, and also the decision and the risk that you've taken. There's a huge risk when you do such things, and you've done a very good job. Really appreciate it.
One or two things, Dr. Chetan. Why was there neck pain and radicular pain 2 or 3 days before?
Yes, sir. He has that C5, C6 disc protrusion, sir. And
what?
usually the mild disc protrusion was present at C5, C6 level, sir. And usually the mechanism in anterior spinal artery ischemia is because of either aortic dissection, and second mechanism is because of fibrocartilaginous embolism.
Correct.
So probably
So
I
did you
thought
think
that
of fibrous embolism, fibrocartilaginous?
yes,
Was
sir.
there any neck manipulation?
No, it was not done, sir.
Somebody gave massage to the neck or something?
No, sir. But
Yeah,
he
because,
used to travel.
this-
He used to travel from Jalgaon to his village place daily on bike. That is around 50, 60 kilometers. He was studying in Jalgaon and he used to go by bike. And so at around 7, 8 p.m., he traveled from Jalgaon to his place, village place. And at 9 p.m., he started having neck pain. So by going on highway, they usually wear the helmets, and on bike, they get a lot of thirst. So that may be the precipitating factor.
Yeah, so see, if there is no aortic dissection, because initially I was thinking of aortic dissection, but if there is no aortic dissection,
Yes, sir.
obviously your artery of Adam-Kravix is involved.
Yes, sir.
So my first thought was fibrocartilaginous embolism into the anterior cerebral artery, but usually that occurs in the cervical spine. This has
Yes,
occurred
sir.
in the thoracic spine, so it's very unusual. And secondly, did you do a scan prior to thrombolysis?
Sir, that was the I have gone little out of the way, sir. He has scan done, which was done on 27th May, MRI scan.
Yeah.
And he presented late at night to me. He presented at
On which date did he present?
29th May, after 2 days.
29. No, I think, see, before thrombolysis, we must always do a scan.
Yes, sir.
Now, I don't know, for the spinal cord, I think MRI is better, but, to do thrombolysis without doing a scan is positively dangerous. So,
yes, sir. I know that,
because, it could be a hematoma, you don't know. It
yes,
could
sir.
be an epidural hematoma, or
Yes,
it could
sir.
be, because of that bike ride, he could have jerked, and, I mean, we don't know that whether it is a ischemic event. So
Yes,
that is a little bit of a risk you took. And I think next time, don't thrombolyze without a scan done a few minutes before the thrombolysis.
Yes,
because,
sir.
These mistakes can happen, and they have happened. And then,
Yes,
later on, if there is a hemorrhage, then really you are in a soup.
Yes, sir.
So those are the 2 points which I would want to make. That what is the etiology of the uh, anterior spinal artery thrombosis, and secondly, the scan has to be done. I mean,
Yes, sir.
even CT scan is okay, because CT scan can pick up hemorrhage.
Yeah.
CT scan of the spine also can pick up hemorrhage, and you can do axial cuts and all. So, to thrombolize without doing a scan, I think we should avoid. So,
Yes, sir.
otherwise, I
Definitely.
think you have done a fantastic job. I
Yeah.
know there were difficulties at your place to do it in the middle of the night and all that stuff.
No,
I know.
I would have done the scan, sir, but it would
Yeah.
have taken around 2 hours after doing the scan.
No,
and all
CT
this.
scan, why should it take 2 hours?
No, I have not thought of doing CT scan. Means it
Yeah,
doesn't
CT
come in
scan,
mind, sir.
see, actually, the thing is that, in order to save time, because this MRI often takes time, often the
Yes, sir.
technicians are not there. And this problem is there all over the world. It's not only in Jalgaon or wherever, it is all
Yes,
over
sir.
the world. So many people, or most people, or level 1 evidence, level 1A evidence is to do a CT scan.
Of spinal cord.
Yes,
Of,
the spinal cord, the level of evidence is not there, but for the brain, it is level
for
1A
brain,
evidence.
yes, sir.
And to do MRI is level 1B evidence. So a little
Yes, sir.
inferior. Now, spinal cord is a very special situation. I don't think it has been studied, but to give a lytic prior without this, I think is dangerous, and one should avoid that. But
Yes, sir.
otherwise, I think it's a fantastic case, and it is really so happy. And why did the cousin also have the paraplegia? I mean, what
Yes,
type
sir.
of familial
He
disorder
also-
is this?
No, I have tried to say, sir, but there is no familial link which is
Yeah,
there.
because it's very
I think it
unusual
is
for
just by
2 people
chance.
in the family to get spinal cord infarction, and at a young
The
age. How
cousin
old is the
sister,
cousin?
not cousin sister.
How old is the cousin sister?
She is also around 24, 25 years old. Sir.
So in
Young
the
only.
20s to get a spinal stroke in 2 people in the family, it's extremely unusual. So
Yes, sir.
you must look for the cause, and you must try to find the cause, because as it is, spinal cord lesion is unusual, and for 2 people in their 20s to get it, it's extremely unusual.
Yes, sir.
So
2 investigations were recommended,
Huh?
sir. One the 2 investigations in
I
spinal
don't
cord.
know what. Maybe it's a spinal angio you should do,
Yeah.
and a thrombophilia workup. Look for homocysteine, whether that is the commonest cause for thrombophilia in our country. Not all this protein S and C and all that stuff. That's extremely rare. But this is an unusual family. So here we will have to search very, very hard. And what did the cousin sister scan show? Did it show spinal artery thrombosis?
No, there is hyperintensity in the spinal cord. It was in 2017, sir.
Okay.
But she has similar kind of presentation, sudden onset of weakness in lower limbs, and
Yeah.
the diffusion MRI is not
so,
visible, sir.
so it's very unusual to see a case of this type. I don't think I've seen a familial spinal cord thrombosis ever in my life. Anything else, Dr. Jindal or Dr. Anil?
I think, sir,
I've also thrombolized 1 or 2 spinal cord, anterior spinal artery thrombosis, and they have done reasonably well. I wouldn't say they've done as well as your case. Maybe it was late. Here you were very aggressive and very cued in. So I must congratulate you for acting so fast and so quickly. It's really wonderful. And in this forum, I don't think we have seen a case of this type. So many congratulations to you, Chetan. I'm really very proud of you, and really fantastic. Anil?
Yes, sir. Sir, I agree with what you said completely. You know, the medico-legal aspect also needs to be looked at.
Looked
So
at.
a small CT scan, or if an MRI is not possible, at least a CT scan is the way ahead. But this is a very unusual case, and I I have no words. I think he's done a wonderful job. So,
Really,
I,
really.
I would not, I would not have thought of it, or I would not have thought of thrombolysis. I would have probably made a diagnosis and then stayed put. So, it's a
No,
huge
no. So
learning.
next time you will thrombolize.
Yes, I will.
Next time in your long career, when you see such a case, thanks
Yes,
to
sir.
Chetan Chaudhary, you will
Exactly.
thrombolize.
Exactly.
Yeah,
So
two
that's the whole
investigations we
idea
need
of
to
this
do, sir.
forum. That's the whole idea of this forum. We learn from each other and we see something unusual which we've never seen before. And really, it's really fantastic, Chetan. Really fantastic.
Thank you, sir.
Yes, Dr. Jindal.
Yes, sir. It's or you have already said that at least medico-legally we should be very alert nowadays, because there are lot many litigations, and at least we should do plain city in all these cases, at least. So that can save us. We are trying to save the patient, but we should first of all try to save us. then only
Yes.
we will be able to save the patient.
Yeah, exactly. Exactly. Okay. So I think so. Still, we don't know the etiology. Chetan, I think you have to dig a little further.
Yes, sir.
Maybe you do a spinal angiogram or an aortogram and try to see if there is any lesion there. Huh?
Yes, sir.
I mean, why should it occur in a 20-year-old? I don't know why it should occur.
Yes, sir.
Okay. Okay. Dr. Badresh?
Yes.
Yes.
Can you hear
Would you
me?
like to take your case?
Yes, yes. I have given
I
the
will-
case to.
Yeah. I will be sharing your case, sir.
Okay.
Please let me know
Thank you.
when to switch to the next slide.
Yeah, we'll start. Okay. So I'm going to present a case, thrombolized few years back by Tanaki Place. First slide. Next. 72-year male. He was the father of a doctor. He was MBBS. His son was MBBS, and this person was astrologer. He was non-diabetic and non-hypertensive, right-handed, and he was also graduate. Next. He presented with difficulty in understanding. A relative says there was difficulty in hearing, not speaking anything since last 2 hours, no any significant limb weakness. Next. So it was actually referred by that MBBS person to me. And when he was admitted, the pulse was 120, but it was irregularly regular. Blood pressure was around 140/90. Respiratory was 14 by minute. Sugar was 101 milligram per DL. And CNS examination, I see global aphasia. And there was right upper limb and lower limb drift. Right plantar was extensor, and there was a slight facial weakness. Imaging, actually, I advised, but he came with imaging. So next. This is ECG, Hazrat. It's not seen so, but you can see there is a irregular rhythm and P wave is not seen. This is very old case. So this was ECG showing the atrial fibrillation, and rate was 120 nearly around. And he presented with me with brain MRI with angio. Actually, we do generally CT or CT with angio, but he directly presented with to me with MRI angio. So you can see there is a large infarct in the speech area, the Wernicke's and Broca's area. Next. This is the MRI angio. There is a attenuation of the M3 vessels, more over the left side. Also, there is also right side. There is attenuation of the vessels in M2 or M3 segments. Next. CBC was normal. There was no contraindication to TPA treatment. NIHI score I counted, that was around 5. Next. So tenecteplase was given according to 0.2 mg per kg according to weight. There was no worsening. After 1 hour, significant improvement in speech was seen. He can speak but cannot comprehend, write, or read. Naming was also impaired. Next. We did some routine investigation in the stroke echo because atrial fibrillation was there. So we did the echo that LV function was 60%. There was no clot, and so there is LV hypertrophy. Next. Other investigations were done: RFT, LFT, electrolytes, thyroid, and lipid profile. Everything was normal. Next. After CT, 24 hours after CT, there was no bleeding, and there was improvement. Clinically, there was improvement. Next. Now there was a problem because I suspected cardioembolic stroke. There was atrial fibrillation and rate was higher than the 100. But there was also some kind of atherosclerosis. I noted that the vessels were narrowed. So I also started ecosprin 150 and enoxaparin 0.60 BD. And I took the advice of cardiologist. He started metoprolol BD until the resting heart rate was 80. He also started amiodarone to 200 milligram BD, and statin, rosuvastatin was given to 10 milligram. Next. After 5 days plan, there was a plan to shift to the anticoagulant as there was no Hughes infarct. So we plan to shift to the anticoagulant. Next. So I see the CHAD-VASc2 score, CHAD score, and CHAD-VASc vascular score. So this recommended high. Patient was slightly pre-hypertensive stage. Age was around nearby 74. And there is a stroke. Next. And as I also did the Hasbled score that recommended hypertension, abnormal. There was no renal or liver dysfunction. Stroke there was present. There is no bleeding tendency or predisposition. Patient was not any anticoagulant, but his age was more than 65. He was not on drug or any alcohol. Next. So we can see it in this case, CHAD-VASc2 score was 4 and Hasbled score was 3. So I plan to give him direct thrombin inhibitors. Next. So according to European Society guidelines, atrial fibrillation risk stratification and oral anticoagulant treatment, if CHAD-VASc2 score is more than 2 and Hasbled score, I consider also Hasbled score. So I started direct thrombin inhibitor. Next. Direct thrombin inhibitor, I started dabigatran 110 milligram BD with ecosprin 150 milligram per day. In follow-up after 2 months, actually it was in 2018. So patient can speak, normal comprehension was there, repetition was normal, reading and writing was normal. Still, occasionally there was naming difficulty, no any limb weakness. As he was an astrologer, so I recommend him to write a page. Next. So after 2 months, you can see this is in Gujarati. He wrote a big lesson, and his name also, with Sri Ganesha and Namah and everything. So the beautiful writing by patient. Next. Thank you for this. So there was an excellent result in this case I found in global aphasia.
What was the door to needle time?
Yes, sir. Pardon, sir.
What was the door to needle time and stroke to needle time?
Yeah, it was 2.5 hours.
For what? Stroke to needle time?
Yeah, stroke to needle time. Because he presented 2 hours late. Because he presented 2 hours late because his son did the MRI first. MRI with angiography. And he presented to me with MRI directly. So time has gone to 2.5 hours. That was because his son he was MBBS, so he did not recognize that it's a acute stroke was not.
Yeah. Yes, so this we have noticed many times that when another hospital is involved and then they come to a stroke center, always there is wastage of time.
Wastage of time.
So, they go to a peripheral hospital, which is not a stroke ready hospital, and then they come to a stroke ready center. So, as neurologists now, I've been thinking about this and, ruining it, and breaking my head that, we have to go out into the community and inform people, inform lay public, inform general practitioners, inform consulting physicians that, see, you for stroke, you have to come to a stroke ready hospital. Going from scan center to scan center, doing the scan, then coming to this thing, it always wastes a lot of time. And earlier you treat these patients, always the results are better. So door to needle time and stroke to needle time, to reduce and to improve the functionality of the patient, it is imperative that the patient comes to a stroke hospital. And, we have to tell this and go out into the community and give lectures on this. There are many factors why these patients don't come in time, but it's so distressing. They go to some small hospital, they waste time, they send the patient to some other hospital or other MRI center, standalone MRI center, standalone CT center, and then they come through all the traffic that all Indian cities have faced with. So, this thing, we have to encourage people to come directly to the stroke hospital. Unfortunately, I've been breaking my head on this issue. I've been failing miserably, but there have been some successes, and so we must continue with this effort. And very often, sorry to say, very often we find, when a consulting physician is involved or a GP is involved, often there is delay. I should not say this with some of my colleagues and who are my friends, but this is the bitter truth.
Yes, sir.
So I'm sure, Dr. Jindal, you have also faced this issue.
Yes, sir. Similarly, similar.
It's
same here in Delhi also.
Yeah. And with the traffic in big cities, it's very difficult for patient to come in time. Even the ambulances get stuck in the traffic.
Yes.
So these are things which we have to fight, and these things are important. Dr. Bhadresh, in your case, there was a previous stroke also on the other side.
Yes.
On the right
that
side,
was on the left. I think that was on another side. There was a scar.
So,
I think, yeah.
So actually, this patient should have been on NOACs right from the beginning, because there was a previous stroke. If there is already a stroke, that means the CHAD-VAS score is definitely more than 2. You don't have to think, is there hypertension, is there LVH, is the age this? If there is a stroke, CHAD-VAS score is more than 2. If it is more than 2, means you have to anticoagulate.
Yes.
And this is
one thing.
Yes.
One thing I would tell you that this patient then was not in follow-up with me. He went to some physician and he converted to warfarin, and he then presented with INR 9 to me. Then I again shifted him to dabigatran, 110 milligram BD. Then he was stable. So there was at this 74 age, I have seen that this oral direct thrombin inhibitors may be useful. There was labile INR in this patient.
There is no doubt absolutely that DOACs are better than warfarin.
Yeah.
In the dose of 110, it is equal to warfarin, and in the dose of 150 BD, it is superior to warfarin.
Superior to warfarin, but
the most important thing is that intracerebral hemorrhage is much less with dabigatran than with warfarin. So there are compelling reasons to use DOACs now, and that is level 1A evidence to use DOACs compared to warfarin. Warfarin we would restrict to people who have prosthetic valve or severe rheumatic heart disease with AF. But otherwise, in non-valvular AF, there is absolutely no doubt that the drug of choice is DOAC, whichever one you like. But whether it's dabigatran or apixaban, that hardly matters because there's no head-to-head study one over the other. So whichever one you want. And there are so many conveniences of using DOACs.
Sir, may I ask you one thing?
Yes.
Sir, what's your experience in cases of like cortical vein thrombosis or sinus thrombosis?
We are now using dabigatran for all these cases.
Okay.
Not using warfarin anymore.
So you have
because you know this labile INR and this checking the INR, you know, every 10-15 days. The labs are also not properly standardized. You get some crazy result. You don't know what you're dealing with. There is so much patient anxiety, waiting for the report, spending the whole day waiting for the report, then showing that report to the doctor. You know, so actually it is wasting so much time and effort. And so, you know, everyone used to say that, no, people in India cannot afford NOACs. But actually, if you see now with generic molecules also coming in, that it is fully affordable, and you don't have to do the INR, and you don't have to undergo the anxiety and showing the doctor all the time these results. So,
sir, out of these 2-3 DOACs like rivaroxaban and apixaban and dabigatran. So, what's your experience mainly in stroke and CVT? Which molecule you prefer, sir?
I prefer dabigatran, but you know there is nothing more because you know there is an antidote available, and you know we've had to use sometimes the antidote. But it depends on patient characteristics. Suppose there is renal failure, and you know GFR is poor, then we would like to use apixaban. Suppose there is GI disturbance, we would not like to use dabigatran. Suppose the person cannot swallow the tablet whole, then we cannot use dabigatran. You know, so there are individual characteristics of patients where we select the appropriate drug. But as far as effectiveness is concerned, though there is no head-to-head study, I think the effectiveness is more or less the same.
Okay,
so
sir.
Effectiveness and bleeding risk is more or less the same. It depends on the situation. Liver failure is there, hepatic failure is there, GI disturbance is there, the PPI is going on, you know, things like that. That helps you to decide which NOAC to use. But otherwise, for effectiveness for the usual run-of-the-mill patient, I don't think there's any difference. Anil, would you like to comment?
The only thing I would like to comment in this case is that the global aphasia recovered very well. You know, that's something which we don't so commonly see. In fact, if you see the writing also of the patient, usually they stop at conduction aphasia, like most patients who have global aphasia when they recover. And here this patient's writing also was pretty good. So I think here probably the patient had some association areas which were spared, you know, which actually helped in the recovery when you look at it, or probably the perfusion was well maintained. You know, that's the only thing which I would like to comment, because when someone has global aphasia, we've seen so often that even after you thrombolize, there is some sort of a residual sort of a deficit, which is usually unmasked whenever they are, you know, like you make them read or write. And out here, his writing also was pretty good. So, you know, that's one thing which I would like to comment. It's actually a very good result here for the patient. But yeah, otherwise, I think it's a cardioembolic stroke, and patient should have been on actually a NOAC earlier itself, which should have prevented the stroke in the first place.
And Dr. Badresh, why did you add aspirin?
I was reluctant initially, but I thought that both-sided MCI, if we see the middle arteries, middle cerebral arteries, there was attenuation of the M2 and M3 segments. So I also thought there may be some atherosclerotic pathology associated with it. So I used ecosprin. So it may be
But
some
it
combo
increases the
dangerous.
bleeding risk. Huh?
Yes,
It
yes.
increases the bleeding risk.
Yes, you're right, sir. But I thought that may be the reason. That's why I added. So I suspected two etiology, cardioembolic as well as also some atherosclerotic etiology.
No, actually, this time of flight TOF MR angio is very poor.
Poor, yes.
In determining atherosclerosis, really. And another thing is, you also gave enoxaparin. Actually, there is no role for enoxaparin. So if we have to start an anticoagulant, according to Diner's, not law, I would say, Diner's hypothesis, according to the day, you can straight away start DOACs, on day 5 or day 6. There's no need to pre-treat with low molecular weight heparin.
Yeah.
So this is a good case. Even with low NIHSS, you said NIHSS is 5. But the deficit is very disabling. It's very disabling. Aphasia, global, or even Broca's, or even Wernicke's is highly disabling. So even if NIHSS is 2 with a disabling stroke, you should thrombolize the patient.
Yes, sir.
Just don't go by it, because NIHSS in these particular situations always gives you a wrong impression. So if it is low NIHSS but disabling stroke, this is a case for thrombolysis.
Yes.
And I think you have done extremely well in treating this patient, and many, many congratulations to you for treating this patient so well. And many, many times we have found that, M2 and M3, they just dissolve with tenecteplase. So, with large vessel occlusion, this is not very large vessel occlusion. I would call it medium level occlusion, medium vessel occlusion. So this is the exact and most appropriate case to give thrombolysis. And it has shown in the results. There could be an infarct, there could be a small infarct, but you've saved a large part of the infarct, large part of the penumbra and the oligemic zone, and probably you've recanalized the vessel. So many, many congratulations to you for treating this patient and reducing his morbidity. Because aphasia, for anyone, everyone says that no, if he's a professor, aphasia is important. But aphasia is important even for a housewife or anyone. If you can't speak, it is highly disabling. So, just because he's an astrologer and he has to talk to people, or that is all nonsense. Any patient, even housewife or anyone, aphasia is highly disabling. So you must aggressively treat these patients. Any comments, please, from Anil and Dr. Jindal?
Sir, you rightly said it's not only aphasia, but like agnosia or prosopagnosia, or sometimes homonymous heminopia, they all are indication. Many times in patient parts, you find only homonymous heminopia. And
homonymous heminopia is very disabling, because you can't drive. You can't drive. And, so don't take it lightly, don't take it lightly. It is highly disabling. So even though NIHS may be 2 only, if you see heminopia, if you see the NIHS,
it will be only 2. Only 2.
But it's highly disabling. You cannot drive. You become dependent on other people. and then, with the hemianopia, you may have the reading difficulty. You may have, not word fighting. You may have prosopagnosia. You may have so many other things. So these are not contraindications by any chance, by any stretch of imagination. Yes, Anil?
Yes, sir. So I completely agree here, sir. Sir, in fact, that's something which we often miss. NIHSS is misleading for aphasia and hemianopia. So, I think it's far more disabling. So, and it's often not taken into account. So we always say that the patient has a low NIHSS and we don't thrombolize these patients. In fact, we should aggressively thrombolize almost all patients. This is how I believe, because I've seen patients where we wait and then a few hours later they worsen and then we've lost the window for thrombolysis. So that's the way I go about it.
Yeah. So I think we've discussed everything in this case. The points we made was that patients should come directly to a stroke center. Very important, and therefore we must go out into the community and educate the lay public and doctors especially. And the more doctors who get involved, the less likely that thrombolysis will occur because of delay. Therefore, no, it's true. I'm sure you have also faced it. And, opinion after opinion, and, then phone up this fellow and phone up that fellow. And they're not so aware as we are, of thrombolysis. So they don't know. They don't know the benefit. They've not seen the benefit. We have seen the benefit on day-to-day basis. So we as leaders of this thing have to go out and educate these people. And sometimes you have to be a little rude also. But you have to be rude to be kind, so it may sound rude, but it's not rude actually. It's for the patient's benefit. So it's not rude, but it sounds rude to some people, and they get angry and offended. But there's nothing to get offended in science. It's a science. People, if they get offended, it's their problem really. So we have to be firm in our decision. And we've had two very, very interesting cases. Ketan's case was just amazing. And Bhadrash's case also brought out so many important points with management. Patient should come early, low NIHSS should be treated, the use of DOACs, when to start DOACs, what rehabilitation you should do, how you should treat AF, how you should bring down the rate, involve the cardiologist. So many important micro decisions have to be made in every stroke. So it's not one decision of thrombolysis. There are so many decisions. Admitting to ICU, treating the AF, when to start DOAC, which DOAC to start, how to see the creatinine, the change over from warfarin to DOAC, whether to give aspirin or not. There are so many, in every case, there are so many micro decisions to be made. And each decision is so important for good patient care. So both these cases, I think, have brought out many factors in stroke management. And I think we have learned a lot. So I will ask for closing comments from Dr. Anil and Dr. Jindal. And I'm sure we have enjoyed this evening very, very much. Anil.
Sir, one question.
Yeah.
Sir, anybody has thrombolyzed in the CRO, central retinal artery occlusion? I have two patients.
There is no RCT. There is no RCT, so there is no guideline. If there is no RCT, there cannot be a guideline. But people have done it. The thing is that it has to be detected early.
Yes, sir.
People have thrombolyzed. Some of our doctors in Maharashtra, one Dr. Dhonde from Nanded has thrombolyzed 2 patients, and they have done well. Even with branch occlusion, retinal branch occlusion with altitudinal field defect, you can thrombolyze. Of course, you have to do it within the first 4.5 hours. It's very difficult to do mechanical thrombectomy because the vessel is very small. but there is definitely a role for IBT, but it is not in the guidelines because no trial has been
Guidelines,
done.
yes.
But there are many things which are
Okay.
not in the guidelines. That doesn't mean that you
Yes, sir.
should not do, because guidelines can
Okay.
only come if there is an RCT. If there is no RCT, how can there be a guideline? So,
I have
Yes.
thrombolized one case. One case, and that patient had a complete recovery.
yeah.
So,
So,
it's my personal experience with one case. But again, it's anecdotal. But we had no option. We went ahead with all the risks we explained to the patient, and patient showed a fantastic recovery. Yes, it was in the first like 2.5 hours. The patient had immediately presented. The ophthalmologist made a diagnosis, sent to the ICU, and we just thrombolized the patient. We'd already got a scan done also. We only got a CT done, but clinically everything was in favor, and patient showed a very good recovery. So, I mean, I think such cases you have to take it on a case by case. You can't just wait for evidence. You have to weigh the risk benefit, and then you will have to go ahead. That's how.
absolutely correct. Absolutely correct. So, anecdotes also have made history. And, every time you can't have an RCT.
Exactly.
Anecdotes, anecdote Jenner, when he gave the smallpox vaccine, was anecdote.
Syndopa.
Rabies vaccine, it was anecdote.
So levodopa was an anecdote.
Anecdote. So, anecdotes make history. So don't disregard anecdotes. They are important. Chetan Chaudhary, by thrombolizing this thing, it is an anecdote, but it has shown improvement. Now, there is no RCT on anterior spinal artery thrombosis. But you have to be sensible, make proper decision, and take patient into confidence and do it. I mean, there is no harm. I mean, you write down, you safeguard yourself, of course, properly, and do it. I mean, nobody's saying no. And there is literature evidence also, Anil, on this. Though there is no RCT, there are anecdotal reports in the literature also. So you are protected. And, the risk of thrombolizing a stroke mimic. Suppose, it was not anterior artery, CRO. It was something else. Very unlikely that it was something else. But for argument's sake, suppose it was something else. Even to thrombolize a stroke mimic, the risk is less than 1%. So when my philosophy is, when in doubt, thrombolyze. Don't find an excuse not to thrombolyze. Find a reason to thrombolyze. Don't find an excuse not to thrombolyze. There are many people who are negative, I mean, it depends on your mindset. Many people who are negative, they will find a reason why you should not thrombolyze. But it is important to find a reason to thrombolyze, not an excuse not to thrombolyze. So it is a mindset. And I think we have to change mindsets of people. It's difficult to do that, but we have to do it. Dr. Jindal?
Yes, sir. You are rightly said, sir. So, first of all, we need to create awareness in our surrounding, in our periphery areas, like in our vicinity where we practice. So, we need to educate our colleagues, our small nursing home owners and all that, so that we can increase more and more patient thrombolysis, so that more patient can get benefit out of thrombolysis. So in Delhi, I am doing this in my vicinity. In around 8-10 kilometer areas, there are so many nursing homes. So what I used to do small CMEs. I used to offer them cocktail and dinner with the RMOs, with the resident doctors. So I sensitize them so much that whenever any patient come to them with the acute stroke-like symptom, they immediately send the patient to me. So that's why I used to thrombolize so many patients. So I think that's very good strategy, that we should capture these small nursing homes, because most of the time patient first of all will go to their nearby small nursing home, not directly come to big hospital. So I think these are the areas where we can tap and we can educate our colleagues over there, so that maximum patient can benefit of thrombolysis.
Yes, sir, absolutely. And you have to give the cocktails, otherwise they don't come.
Yes, sir. That's important.
And that is the bitter truth.
Bitter truth.
But it is there. It is there all over the world. It's not only in
All over.
India, it's all over the world. So nothing to feel shy about. And we
Yes, sir.
must do this. We must do
Yes, sir.
this. I think we can end now.
Yes, sir.
We are a little bit over time, but I must say it was a fantastic evening and
Same.
I learned a lot. Dr. Ajinkya, would you like to
Yes.
take over?
Yes, sir. Thank you so much, sir. It was a wonderful, wonderful workshop, sir. And both the cases were very unique and informative. And I would like to thank and congratulate Dr. Chaudhary, sir, and Dr. Mangukia, sir, for presenting those interesting cases. And also thank you so much, Dr. Ichapolia, sir, Dr. Jindal, sir, Dr. Venkatachalam, sir, for your expert comments and the great practical insights. And we would like to really work under your guidance for many such future programs. So with this note, we will close this session. Thank you everyone again.
How
for
many
joining.
people attended today?
Let me check, sir. Around 100 is there, sir. Yeah.
The recording has stopped.
Around 127, sir.
Good. That's a good number.
Yeah.
But we are down. Usually we are more than 200.
Yeah.
Yeah, okay. Maybe it's December and it's party time.
That may be one.
But it's weekday, sir.
Anyway, good night and all the best.
Thank you,
Good night.
sir.
Thank you.
Thank
sir.
you.
Thank
Thank you,
so
sir.
much, sir.
Good night. Thank you.
Good night.
Good night.